Hello everyone, I am Dr. Abraham from A&E Dermatology Specialist Uganda, and today we are going to have a session about syphilis, also called Lewis. So this is one of the common conditions that people diagnose, especially the general practitioners. Every time someone gets stuck, they think it is syphilis. Today we shall look at what syphilis looks like and what it doesn't look like. So sometimes you may think that everything is syphilis, which can be partly right. This is because syphilis, we call it a great mimicker, since it can look like any other skin condition. And at the same time, you have to remember that it also used to be called the great pox, especially in the 16th century. This was aimed to distinguish it from the smallpox by then. So today we shall look at how syphilis comes about and how it looks like, and then we get a good understanding of how to diagnose and then come to a conclusion that the patient has syphilis. So it is one of the bacterial infections caused by this bacteria, the spirochete, we call Treponema pallidum. The subspecies is pallidum, and typically it can be transmitted from one individual to another through sexual contact, or it can be acquired transplacentally, that is vertically from mother to child. And in case syphilis is untreated, it can progress through different stages. As we are going to see, it can start from primary syphilis, secondary syphilis, all the way to tertiary syphilis. And each stage of syphilis has its particular presentation, as we are going to see. So in the nomenclature, the name syphilis was coined by an Italian poet, Francesco, in the 1530s. And it is this gentleman that came up with this name syphilis, and it was inspired by actually his own poem, which he had titled Syphilis, Survive Morbus Gallicus. And it was called the Great Imitator and also the Great Pox in the 1960s. That time they had two outbreaks. There was an outbreak of smallpox as well as syphilis. So syphilis was called a great pox, whereas smallpox remained as smallpox. So we've seen that when you go to epidemiology, so syphilis is one of the conditions that has kept having a variable incidence and prevalence depending on the time period. So initially, it used to be very high, especially during the Second World War. After the Second World War, syphilis had picked all the way up. Almost everyone had syphilis. But later on, after the introduction of antibiotics and the rest, its numbers kept going down. But then you are seeing it rising again, especially because of the current sexual practices. So men having sex with men have particularly shown to show a higher instance of syphilis, going to as high as 7.5%. And this is really worrying because this is an increasing trend. And this particular group of people is actually now also getting to get this syphilis. So they're going to transmit it to other people, and then the cycle will continue. So when we look at the update, maybe starting from around the 2022, that is like 2 years ago, according to WHO, it estimated about 8 million new cases of adult syphilis and about 700,000 congenital cases of syphilis. So in this case, they showed that about 150 cases, there were early fetal deaths and stillbirths because of syphilis, and then 70,000 they were neonatal deaths, and about 55,000 they were preterm and low birth weight children, and about 115 they were about infants with congenital syphilis. That was about 2 years ago. So meaning that the burden still exists, and you need to know how to manage and treat and prevent a spread of this bacterial infection. So as you can see in this map, it shows you the different trends of syphilis over a couple of years. And you'll find that around this period here, we had a peak that is about the Second World War. And then there was a decline. And then later on, we had another spike in around the 1976. Then in around 2003, there was a continuous rise. And currently, we find that ourselves also having something similar occurring. So when you go to the pathophysiology of syphilis, so syphilis is caused by the bacteria, as we've said, the Treponema pallidum, and it is a little bit very elusive bacteria because even after all this time, we don't have a clear pathogenesis of how it causes actually the syphilis, but still we are having theories despite it staying with us for all this time. So starting with the bacteria has special features or what we call virulent features that make it a little bit evade the immune system or stay in you without your immune system actually noticing. The first one is that it has the outer membrane, what we call the outer membrane, like bacteria have the nuclei, the cytoplasm, then the cell membrane, and then the cell wall. Now, for the syphilis, it is its outer membrane. It's supposed to, in other bacteria, the outer membrane usually expresses the antigens that your immune system picks up, and then it mounts an immune response to get rid of that particular bacteria. But now, when it comes to syphilis, its outer membrane actually lacks the lipopolysaccharides that are seen in other bacteria, and it just has a few transmembrane proteins. So, because of this, it is a little bit like not even how can I say, hypoantigenic, meaning that it doesn't express a lot of antigens for your body to come and mount an immune response. Then the other thing is that for it, the lipoproteins that are immunologically active, that are good, strong antigens, they're actually expressed within the inner surfaces of the cell membrane, meaning that they have no access to your immune system. So this usually avoids the direct confrontation between syphilis, the bacteria, and your immune system. So that is what makes it a little bit more pathogenic because your immune system cannot easily get rid of it once you are infected. Then it is also key to note that syphilis has been shown to show the TPR gene that occupies about 2% of its genome. And this gene is very key because it encodes potential virulent factors that are targeted by the immune response. And you find that there's a very low or the protein from this gene, the TPR gene, the proteins from it show antigenic variation that usually confuses the immune system. So, for example, on day one, it shows maybe the protein has a particular antigen set of amino acids it is expressing. But when they produce another protein, the second day, it has a different configuration, meaning that if your immune system was forming antibodies against the previous antigen that was expressed, when by the time the antibodies come, there's already change in the antigen, so you cannot fight that particular bacteria. That is the antigenic variation. And then when you look at the immune response, so the primary immunogen for syphilis is the 47-kD membrane protein, which stimulates the tumor necrosis factor, the TNF factor alpha. This usually drives the immune response, but it also has other additional antigens, which can be detected by the Ig immune response, and then this helps you to fight the bacteria. The other antigens, we have the 65-kD antigen, shared with the non-pathogenic terpenomes, the ones that are commensal, that are usually on the normal flora. And then you also have other specific antigens that include the 44.5, 17, the 15.5 Kd, and this is usually unique to the species, the Treponema pallidum that causes the infection in humans. And these also aid in immune response differentiation. So because we know that we also have other commercial spirochetes on the skin, so these ones tend to show antigen variation from the ones that your body knows, but at the same time, they don't have express these antigens for your body to pick them up. So when we look at primary syphilis, usually this is the first stage upon infection. Maybe say that you had a sexual interaction, maybe the mother has transferred the syphilis to the child either during childbirth or within the intrauterine life. Usually start with what we call the primary syphilis. And initially, someone will get the initial lesions of primary syphilis, which is typically a solitary non-tender genital chancre or swelling, which can sometimes usually locate in the genitalia, but sometimes can be on other sites, including the lips, including the soft palate, including the tongue, or anywhere, even on the body. But commonly, we usually see them in the genitalia or in the genital areas. But we have also reported them to see on the fingertips, on the nipples, on the also on the mucosa. So now syphilis has a very varied incubation period, which ranges between about 10 days to 90 days or even 3 months, with a median being about 21 to 25 days. So meaning that for some people, upon infection within 10 days, you can get the primary chancre or the syphilitic chancre. But others can take as long as 3 months, meaning that when someone has a non-tender genital chancre or ulcer that is a little bit swollen and indurated, you need to ask them their sexual contact for the past 3 to 4 months. They have to be able to tell you if they have had unprotected sex in that period of time. It may not be just only the last week or last month. It can go as backwards as many as 90 days. Then, without treatment, these lesions usually heal without scarring. But sometimes, if someone has other co-infections like maybe HIV, they can just advance to secondary syphilis right away. But sometimes, if someone is immune competent, these lesions will heal without scarring, and then later on, they advance to secondary syphilis after a very time. Then what you have to note is that primary syphilis, it also comes with a lymphadenopathy, which is bilateral, sometimes tender, sometimes non-tender. So if the lesion of the primary syphilis is in maybe on the penile shaft, you will find that you have bilateral inguinal lymph node swellings, which are either tender or non-tender. And this is point to note because other sexually transmitted diseases, as we're going to see in the subsequent videos, you will find that for them, their lymph nodes are either unilateral and maybe tender. But in syphilis, they can be bilateral, tender, or non-tender. So that is also key because it helps to distinguish it from other conditions that can give you a chancre. So when you go to secondary syphilis, in secondary syphilis, this is the disseminated type of syphilis. The infection spreads now from the primary site, hematerogeneous through blood, causing a wide range of manifestation. And in this case, you have other skin manifestation, including the condyloma lata. You can have a rash, which usually also affects the palms and soles. You can get lymphadenopathy, as well as you can get other things like alopecia, hepatosplenomegaly, and other things like malaise and joint pains, as we are going to see. Then later on, after the secondary syphilis, then we go to what we call latent syphilis, whereby now the bacteria will go for a rest, and then on a way to cause you later infection, what we call now the tertiary syphilis. So under latency, someone actually has no symptoms, but the bacteria can be picked up on the routine serological investigation. So in case untreated, we end up with tertiary syphilis. And in tertiary syphilis, we have complications that can usually involve the cardiovascular system, the sinus system, and then will also involve the skin, as you are going to see. So when you go to histopathology, like if you take off a sample in syphilis, what do you see? So we know syphilis is a bacteria that affects blood vessels. So someone will end up with what we call the end arteritis. And in this case, it is an inflammation of the blood vessels, especially the arteries. And this is what we will see even on histology. So in the pathological changes, if it is consistent with the uh, uh, if you're looking at all the stages of syphilis, you will find that the vasculature involvement is almost similar. So it will cut across either you're dealing with early syphilis, secondary, or even late syphilis, and that will be now involvement of the blood vessels. So you will have perivascular infiltration, which will be composed of both lymphocytes and plasma cells that is around the blood vessels. And at the end of it all, we end up with the end arteritis obliterans or narrowing of blood vessels, especially the arteries, but as well as the veins can also be involved. In this case, you have inflammation. You see when you have inflammation, blood vessels healed by scarring, and forming scar tissue. So in this case, you'll end up having thinning or narrowing of blood vessels uh, uh, as the manifestation. So in early lesions, you'll have infiltration first and then ischemia. The infiltration will cause a terminal proliferation leading to tissue ischemia and ulceration. And then in this case, will you be able even to detect the spirochetes within the capillary or even the lymphatic vessels? If you do the levaditis stain, or even if you just do fluorescent antibody or even the immunohistochemistry. But then when you take off lesions from the skin, you'll be able to see endothelial swelling or even psoriasiform pattern, or sometimes even lichenoid pattern, but you'll have infiltration having plasma cells, lymphocytic cells, and the rest. And then in the late lesions, in the late lesions, you form what you call the gomas or those granulomas. And in that case, you'll have infiltration having histiocytes, fibroblasts, and then epithelioid cells. So this is also very key for you to know that syphilis is one of the conditions that cause granulomatous changes. So meaning that when you take off a biopsy and then you see a granuloma, you have to have a list of things that you should be including in your differentials. So in this case, we see, for example, this is a picture of a slide done from a patient, a 53-year-old man who had a papillosquamous eruption on the chest and the back. And then you see this dense lymphocytic infiltrate. You see all these lymphocytes around these lesions. And then when you look at the blood vessels, for example, this is one of the blood vessels with blood even inside. You see this infiltration of lymphocytes even around the blood vessels. The same picture here, the same picture here, the same picture there. And in this case, you need to tell a difference. How do you now get to tell that this is actually syphilis? You can do a special stain. So in special stain, you do immunohistochemistry, and in this case, you see the spirochetes, as you can see here. So all these that are stained, these are the spirochetes that you can see, all of them, especially around the blood vessels. This is another one. So now this one I try to put this one to show you that now when you do immunosustaining, you see that, for example, this was a blood vessel here, but now the wall is almost obliterated, and then you have this infiltration of these spirochetes or these bacteria. And all of these ones are what you call the spirochetes or the Treponema pallidum. Then Treponema pallidum, this bacteria is special because it was first described by Hoffman and a friend, or isolated in the 1905. So initially it was called Spirocheta pallidum because it is a spirochete, and then later on the name was changed to Treponema pallidum. So this is one of the bacteria that cannot be cultured or propagated even up to date. But its culturing has only been possible in the testes of rabbits. So, but for the rest of the normal culture media that we have, either blood agar or whatever agar you have, does not grow there. It can't grow there. It is very fastidious, requiring particular temperatures, particular set of nutrients which have not yet been met by the artificially made agar. So it cannot be cultured. Then, morphologically, it is a spiral-shaped bacteria with corkscrew appearance, and it's about 6 to 15 micrometers in length, and it can be well visualized when you do dark field microscopy or if you do direct fluorescent antibody methods. So in this case, remember, you get an antibody that is attached to a fluorescent substance. That antibody will attach the antigens on the syphilis. Then because of the lighting, or then when you do fluorescence, you're able now to pick out the bacteria. And then it has a distinctive movement where it shows you that slow corkscrew or angling motion. And that's how it looks like. So it is a microaerophilic bacteria, highly invasive, and also survives only in mammalian hosts. It can't stay outside mammals. And then its nutritional needs are very, how can I say, fastidious. Like you cannot easily meet its nutritional needs because it requires exogenous amino acids like even D-glucose, even specific serum components, which can only be found in mammalian blood. That's why it is very hard for you to culture it. Then remember what we said, that it lacks the lipopolysaccharides, meaning that it doesn't look, if you can't do gram staining on it, you can't look like the other, either gram positive or gram negative bacteria. And then in the mechanism of invasion, it is thought that it produces hyaluronidase. You know, you have hyaline in the skin. So this hyaluronidase is able to break down the hyaline that we have, then it can penetrate. Then upon infection, it is thought that it also causes a shift from T helper 1 to T helper 2 based immunity, which is a little bit less aggressive when it comes to infection. And this slows down and downregulates the macrophage activity, meaning that you cannot easily destroy this bacterium. Then we know that it also induces local inflammation, and it can easily disseminate, while the immune response of the person, you know, it suppresses the immune system, then it spreads such that it goes wherever it wants, and it can spread either via hematogenous pathway through the blood, even via lymphatics to reach other body parts. Then this is how it will look like. In this case, this is what you see on dark field microscopy. We see these spirochetes having this corkscrew appearance. The same, this is how it will look like on immunofluorescence technique. So when you look at natural history of syphilis, natural history of any disease actually simply means what happens in case someone gets that particular disease, how will they progress in case you don't interfere, in case you don't treat. So now the natural history of syphilis was explained or was described in two studies. We a little bit at the unexposed studies that you have in history. The first one was the Tuskegee study and then the Oslo study. So in this case, they looked at patients who had syphilis, they didn't treat them, and then they monitored them over a very long period of time to see how do they progress. So the first one we start with is what we call the Oslo study. So this was conducted in the years between 1890 to around 1910, and it was done in Norway on about 1,400 untreated syphilis patients, and they followed up over a decade of time. So they discovered that of the 100% patients who are infected with syphilis, just a few of them will actually will progress to secondary syphilis. So if 100% are infected, they will develop the initial lesion we talked about, the primary chancre or the fate chancre, in about 3 to 6 weeks. So without treatment, 70% of them actually cleared of syphilis. However, 25% progressed to secondary syphilis. So now, of those that went to secondary syphilis, they went on to develop the skin rashes, the mucous patches, the fevers, and lymphadenopathy. And then these symptoms could resolve without treatment in a few weeks to months. So, and then they went into a latent phase, those that developed secondary syphilis. So now, of people in the latent phase, some of them were now categorized further into early latency and then late latency. So early latency was looked at to be the first year upon infection, and in this case, they discovered that these patients were actually very, very contagious despite them being asymptomatic. And then in the late latency, that is after 1 year, these were non-infectious, a little bit more, they could be infectious, but less infectious, like almost non-infectious, if you had to compare them with those ones in the early latency. And this latency could stay with them for decades. So someone could be actually in latency period for over 30 years. Then about 30% of untreated patients here eventually progress to tertiary syphilis. So, so you need to know these numbers. So we started with, if you get 100% patients, you infect them with syphilis, 75% will clear without progressing. Then 25 will progress to give you a secondary syphilis. Then upon reaching secondary syphilis, most of them would go actually and heal without developing or complicating. Then a small percentage will now go on to develop latency. So now, if you don't treat those ones, so only about 30% of those ones who had secondary syphilis will now go ahead to give you tertiary syphilis. So now, so this tertiary syphilis, as I've said, it had a very varied period, because some of them could develop the condition, the tertiary syphilis, as early as 10 years, but it went all the way through up to 30 years. So meaning that someone can get syphilis in their early 20s, but as they are clocking 60, then they develop tertiary syphilis. And then when it came to those that developed tertiary syphilis, the different complications were further divided into three. We had those ones that had cardiovascular involvement. Those contributed 10%. Then neurosyphilis contributed about 7 to 10%. And then the gummatous or the skin involvement contributed about 15%. So meaning that of the 30%, this is how the percentage was shared amongst the different clinical manifestations. And then the general mortality rate of syphilis was about 10 to 20%, especially those that got cardiovascular involvement and neurological involvement. They ended up actually 20% succumbing to syphilis. So the other study that was described in an attempt to see how syphilis progresses was the contagious study, which was conducted in the United States of America in the years about 1932 to around 1972. And in this case, they were looking at 399 African Americans. Okay, these were slaves that we had syphilis and then were not treated in an attempt to observe what happened to syphilis. And then this one had higher mortality rates were confirmed, especially if someone had comorbidities. Maybe if someone developed cardiovascular syphilis or neurosyphilis, it was associated with a higher mortality rate. And then uh, so in this case, someone could get a secondary syphilis, tertiary syphilis, and then they're just observing to see what happens actually. So it's because of actually those two studies that now people came in to regulate research when it comes to human participants. So despite them doing bad things, at least there's something good that came out. That one, we're able to know how syphilis progresses. Then two, we're able to get regulations about production of human research. And then this is the overall contribution of this to the medical knowledge. With 30%, as we've mentioned, developed tertiary syphilis, mortality of 20%. Then at the end of it all, we're able to get the ethical legacy that after this study, there was a good discussion that led to abolition of studies on humans if you've not studied the condition very well. So you cannot have medicine and then you don't treat someone because you want to see how the disease progresses. So starting with the types of syphilis, starting with primary syphilis. So we start with how does it come about? So usually after maybe sexual intercourse, someone will develop this initial infection, which is at the site of where the skin was lacerated and then got into contact with the serous fluid or vaginal fluid or semen or blood that contains the bacteria. So when it enters the lacerated skin, the initial lesion will be a papule, which will then ulcerate, and then it will give you what we call the typical chancre, the civic chancre, usually about 1 centimeter in diameter. Most of the time, it will be indulated, painless, with a very red border, and oftentimes someone has either one lesion, but some of them can have multiple lesions, especially if someone has anal fissures, men having sex with men. So these ones will end up with very many primary lesions. And then this one we've said earlier that they typically heal in about 3 to 8 weeks, leaving either thin or not even no scar at all. Then the common location when it comes to men, the primary syphilitic chancre, we usually see it on the glans penis or near the frenulum or the foreskin. It can also be seen down below the shaft, especially if someone is using condom. In that case, we usually call it the condom chancre that occurs at the base of the penis or the penile shaft. And then for women, these lesions are usually less visible. That's why when it comes to syphilis, women can spread it left, right, center, because for them, they can get their primary lesion actually inside the vagina, around the cervix, the vulva, the labia, even the urethral orifice. So these ones are a little bit more hidden, and remember they are painless. So someone can go through this without actually noticing that they had this. When it comes to men having sex with men and anal lesions, these ones are usually indulated. They can be very many, and they can come along with anal fissures. And sometimes they can report for you a little bit of pain and itching, especially after defecation. Then you can also get extragenital sites. We've seen syphilitic lesions seen on the lips, on the tongue, on the fingers. Also, especially when you get occupational contact for doctors, you're doing the PR and maybe accidentally you get infected, you can end up with the primary lesion actually on the finger. Then you can also get nodal involvement or lymph node involvement. So in this case, you'll have regional lymphadenopathy, and in this case, we commonly see discrete or rubbery non-fixed nodes, and we can have them involving the inguinal area or any area near where the primary chancre is. So we've said earlier that in syphilis, the nodes can either be tender or non-tender, and they can be bilateral in distribution. So in this picture here, I'm trying to show you how the primary lesion will look like and the different areas. So in this case, this patient had a primary chancre here on the penile head. Also had another one at the shaft. So this is what we call the condom chancre, where it's located at the base of the penile shaft. Then it can also be at the urethral meatus. It can also, in this case, they're showing you how you take off a sample. This is a glass slide, trying to take the exudate from the primary chancre for microscopy. And then it can also be on the lip. This is the lip of a person, but it can also be on the finger. So when you look at the secondary syphilis now, for secondary syphilis, so for secondary syphilis, this one usually comes in a little bit later after the primary infection, and it can be about 8 weeks after the initial infection. And someone will present with a generalized rash with mucosal lesions, and then sometimes with systemic symptoms. So when you do serology will be positive, especially in the even in the immune competent individuals. But when it comes to the immune deficient, sometimes even serology can be negative a little bit. And then the skin manifestations, we can have the characteristic rashes, which are non-itchy. Then we have this coppery red. So we are going to see how they look like. They're usually symmetrical. And depending on the level, the initial rashes are usually macular, which we call the roseiform or roseiform eruptions. Then later on, you go to the papular eruptions, which we call the papulosquamous rashes. So we start with macular rashes. Then later on, the patient will develop for you the papular rashes. Then on top of that, they can also get the condylomata lata, especially in the moist areas that are casing areas, especially in the genitalia, you can get also in the axilla, but in this case, these lesions are only seen in the moist areas. And then we can also get involvement of the scalp where you have the syphilitic alopecia, and this is characteristic because it appears as what we call moth-eaten hair loss. You get patches of hair loss all over the scalp. That can also affect the beard area, the eyebrows, all the hairy parts of the body can be affected. So this makes it very key because you have to distinguish it from other causes of alopecia, including the alopecia areata, including the drug-induced alopecia and the rest. And then mucous membranes can also be involved. In that case, you'll get gray-white mucus patches, which can also be seen on the palate, lips, cheeks, and they can form what we call a snail track ulcers, especially in the mouth, like a lesion that's as if a snail passed there. It will look like that. So this is how the hair loss in syphilis will look like moth-eaten. You see these patches of hair loss without a uniform or well-demarcated border, but you just get as if moth, when those insects eat on the leaves, they usually have those patchy holes in the leaves. So that's what we are having in this case of hair loss. So when you go to systemic involvement, patients can have systemic symptoms like fever, headache, night sweats, joint pains, back pains, and we can also have a neurological impact in about 15% of the cases. This case will present with cranial nerve involvement, and some cases you can also get meningitis, though this is very, very rare when it comes to syphilis. So other organs can also be involved, like the lymph nodes, so you can get lymphadenopathy in about 50% of the cases, and in this case, you can have nodes a little bit painless and rubbery, and then you can also get eye involvement, where you get the pannivitis, and then you can also get organ impact, where you can get hepatitis, myocarditis, for periostitis. So you can also get nail involvement, where you get the syphilitic paronychia. So there's actually a little bit of a few cases, about 15 also, of syphilis involving actually the nails. So even when you get a nail issue like the chronic paronychia, it can also actually be an indication of the syphilitic paronychia. So that's a good differential in that regard. So usually, say secondary syphilis can resolve within a year, even without your treatment. But later on, it will now that just spill to latent syphilis. So most cases in secondary syphilis will progress to latency, and they can actually get recurrence, especially if they're immune compromised. Then they get more episodes of secondary syphilis coming back again, even before they go to tertiary syphilis. So when it comes to secondary syphilis, it presents almost like all the skin conditions that you've ever heard about. Actually, that's why everyone thinks that any skin lesion, it is actually what? Syphilis. So we're going to see the different ways that this syphilis presents on the skin, and then you can actually know that syphilis is one of your differentials almost everywhere. So the first one, we call it the macular syphilis. So in this case, someone will present with the macules, hyperpigmented macules on the skin. They can be on the inner aspects of the limbs, on the face, or anywhere on the body. But in this case, they will be hyperpigmented. But sometimes they can even be at cario. So someone can either get macular or even at cario syphilis. So then after that, you can have what we call the leukoderma syphiliticum. So in this case, it has been reported in areas where maybe someone had other syphilitic lesions, but then later on, as they heal, they leave post-inflammatory hypopigmentation. So that's what we call the leukoderma syphiliticum. And this is actually one of the things that we have had at least 2 to 3 cases in our clinic, where someone has this acute onset of hyperpigmentation following the rash that usually covers the trunk, the face, the scalp. And in that case, that's what we call Leukodama syphiliticum. And it was also called the necklace of Venus. So when you hear necklace of Venus, just remember that is the Leukodama syphiliticum. Then we have the papular type of syphilis, or the papulosquamous types. So these ones can appear after the macular syphilis, and lesions are usually coppery red. So coppery red, they are well demarcated, like they're like copper coins, and they can range between 2 to 5 millimeters in diameter, but you can even have very big plaques, but they usually affect the palms and soles. So every time you see a rash involving the palms and soles, syphilis should be one of your differentials. So this is how they look like, as you can see in this picture. This is how they look like. So this is the coppery red, well demarcated copper coin lesions. Then here you see the same picture, but now on the trunk. So that's why people think it looks like other things. Then you have what you call the annular syphilis. Now, in annular syphilis, you get annular lesions, more common in dark-skinned individuals. They love the perioral area and the beard area. They give you these flat-topped papules with a fine, scaly ridges, as you can see in this picture here. So that is how the annular syphilis will look like. I know when you magnify, the picture is not very clear, but that's how it will look like. You see this well-demarcated annular plaques with a silver with a fine scale or at the border of the lesion. Then we have this other one is a phenomenon we call the Buschke-Olandov sign. So in this case, someone will present with a little bit of puppies that are tender or painful when you press them with a blunt probe. So this sign can be elicited in syphilitic lesions. So if someone has a puppies maybe like here on their hand, then you get a blunt object like maybe a ruler or something, then you press on that lesion, they usually get a little bit of tenderness in that area. So that's what we call the Buschke-Olandov sign that we can elicit in syphilis. And then we can also have it presenting as the follicular or even lichenoid syphilis. In this case, you get very tiny, minute papules that can even look like lichen planus. And oftentimes they can be dome-shaped or it can be grouped. They can also have a scale, or sometimes they can coalesce and give you a plaque. Then you have the Corimbos syphilis. This one, you'll get lesions that will have a very large central papule surrounded by a group of very tiny satellite lesions. So in this type of syphilis, you'll have a large papule like that. Then you have other tiny ones as if they're showing cyclitosis. You know, cyclitosis is the one usually see in Candida. So it can give you a similar picture. So that's why rotating syphilis can look like anything. Then you can also have what you call the pustular ulcerative syphilis, and these are usually two. We are going to look at them. So the first one, we call it the rapile syphilis. So this is usually a superficial ulceration covered by a very thick scale, which looks like oyster shell. You know, oyster shell is aquatic insects, so they will look like that. So if someone has an ulcer, then the ulcer is covered by a very thick scale, which looks like an oyster shell. Then you can also have what you call the Lewis maligna. We said Lewis is syphilis, so Lewis maligna is a rare form of secondary syphilis. And up to date, when I try to review literature, about 14 cases have been reported. And in this case, you get ulceronodular lesions in the case that will look like any other ulcer on the leg. You get it? But in this case, when you take off a biopsy and then you do the dark field microscopy, direct immunofluorescence, you see spirochetes there in the lesions. And when you treat with benzosine, they won't usually heal very, very fast. Then the last type, we call it the condyloma lata, condylomata lata. So in this case, we see it commonly affecting the moist areas, giving you white-like lesions. Now, syphilis is looking like the verruca. So in this case, commonly seen in the genital area and the perianal area. So a condyloma lata, condyloma is just like a mushroom-like plant. It looks like this. As you can see in this picture I put for you here, just for context, so it will look like that. And now, when it comes to syphilis, it will give you those similar lesions in the perianal or perigenital area. So that's what we call condylomata lata. Then we go to the latent syphilis. So in latent syphilis, this is the stage of syphilis that follows the secondary syphilis. So after someone getting secondary syphilis, the body will heal, and then the syphilis goes into latency. So in this case, someone will have no symptoms, but when you do serology and checks, they will be positive actually for syphilis. But they will also be infectious. So that's why the sexual cycle keeps spreading the syphilis, because some people have it in latency and continuously spreading it. So we have what we call early latency, and depending on the reference you're using, if you're using WHO, it occurs about within the first 2 years upon infection. If you're following CDC puts it at 1 year following infection. So we go with WHO, which is the World Health Organization. So we take maybe, in my case, I'll take WHO, which takes early latency to be within 2 years after infection. So it can also be transmitted vertically, that is from mother to child, and also sexually, as we mentioned earlier. So someone will have no symptoms. Then late latency, the one which occurs after 2 years. So in about 25% of the individuals with the latent syphilis experience late manifestation, which can occur even decades after the infection. And then we've seen that latency can go as long as 3 decades. Those are 30 years. Then when you're diagnosing latent syphilis, WHO came up with a very strict diagnostic criteria for you to say that someone has latent syphilis. The first one, you have to check, and there should be no evidence, any whatsoever, or any clinical evidence of active, early, or even congenital syphilis. Is that okay? So if someone has no evidence of active syphilis, then we check. Then two, the CNS analysis should be normal. So when you do a cerebrospinal fluid tap and then you do analysis, it should be very normal. And then the chest X-ray should also be normal. Remember, you have to tell the difference between latent syphilis and then also tertiary syphilis. Because tertiary syphilis can also affect other structures, especially the aorta, the ascending aorta, so it can give you aneurysms and the rest. So if you have to make sure that it's not tertiary syphilis, you have to do an X-ray and prove beyond reasonable doubt that the vasculature is okay, the heart is okay, and the arteries are okay. Then, lastly, someone should have a positive serological test for syphilis, and this should be confirmed even on by a second specimen. You take off the first one, do then the second specimen. If it confirms, then you're able to say that someone has latent syphilis. So the reason of that strict criteria is that because most of the time when people say that maybe latent syphilis, they don't want to treat. Yet in actual sense, someone can actually be having an active tertiary or secondary syphilis that needs prompt treatment. So after that, we now proceed to our tertiary syphilis. So when it comes to tertiary syphilis can manifest after a long period of latency, up to 20 to 30 years. And in this case, we need to know that we have to screen it very well, because as you're giving, maybe these people who donate blood, they can actually spread the syphilis through the blood transfusion. So we have to screen even before you donate your blood. And because of this a new trend that almost everything there's an antibiotic for it. Someone has a cough and flu, they're on antibiotics. Someone has even their own antibiotics. UTIs, antibiotics. So even the manifestation of tertiary syphilis has actually declined to a very, very few cases now these days for us to see. Because we find that most of the time people are on broad spectrum antibiotics, which also have effects, which can also clear the Treponema pallidum bacteria. So it is very hard for you to see this tertiary patient. Then when you go to skin manifestations in tertiary syphilis, so we also classify them. So we can get the nodular or the tubercular syphilis. In this case, someone will have a protruding firm coppery red nodules, which will be larger than 0.5 centimeters in diameter, or what we call the syphilitic gumas. And these nodules can appear maybe cyanotic on dependent limbs, and oftentimes they can also coalesce into groups with a carcinate arrangement. They can also heal, but when they heal, they can also heal with forming of scars and irregular borders. So sometimes when you do histology, they can resemble secondary syphilis, and in this case, they can have also a psoriasiform appearance. And then you can also have the gumatous syphilis. So in this case, you have lesions appearing about 3 to 10 years after the initial infection, and there will be gumata or the gumas. And these are granulomatous lesions. So they can be present with irregular shaped cutaneous plaques or nodules, oftentimes single, but can also be found on the back, the arms, the face, and sometimes they can also have central necrosis and ulceration, so ending up like the wounds, like the ones you see in cutaneous tuberculosis. So these ones tend to grow from the subcutaneous area, invading the deeper tissues, and may also show peripheral tissue paper-like scarring upon healing. And then you can have multiple gumata or gumas coalescing to form complex ulcerations with punched out appearance, which can also be similar to what we see in the bruise ulcer in also pallidum gangrenosum. Then, when you go to neurocutaneous involvement, late syphilis can manifest with the lesions affecting the palate, leading to tissue destruction. Sometimes they can cause destruction of the uvula, scarring, perforation of the hard palate, and all this can occur in tertiary syphilis. And when you have involvement of this perioral area, the oral mucosa, the palate, you can also actually involve the nasal bones, and then you destroy them to end up with a shadow nose deformity, as you see in leprosy, as you see in leishmaniasis, as we see in the uh, rhinoscleroma. So you have to know the conditions that usually affect the central face and they cause destruction there. So other complications, someone can end up with painless testicular swelling, which can mimic even a testicular tumor. You can have others having portal hypertension, which is associated with portosystemic anastomosis. They can also end up with the diffuse interstitial glossitis. So we have to know the difference between this glossitis because there are also other conditions that can present with glossitis, like the oral involvement of other conditions, like the acute glossitis, the vitamin B12 glossitis. You have to distinguish it from the one we see in syphilis. So, so these are the pictures that try to show you what happens in tertiary syphilis. In this first picture here that we have, so these ones are syphilitic gumas, which are now coalescing to form plaques. This is an old picture, one of the ancient pictures. These are gumas, and then in this case, you have them causing ulceration, giving you these punched out lesions. And you see that there's even a connection between these ulcers. Then in this case, you have damage to the hard palate with perforation actually. So you can, this same patient also had the saddle nose deformity. So you have to be very careful when managing syphilis because it has very, very bad effects. So when you go to the tertiary syphilis, as I mentioned earlier, we get mucocutaneous involvement, cardiac involvement, as well as a CNS involvement. When you go to the neurological involvement, we have what we call neurosyphilis manifesting in various forms. So most of the patients, they can have asymptomatic neurosyphilis. About 10% of these patients with latent syphilis can have asymptomatic neuroinvolvement. Oftentimes, this can precede the other bad manifestations, or sometimes can even heal without them noticing. Then we have the second type, the one we call meningosyphilis. So in this case, someone gets meningitis because of syphilis. So they have symptoms like headache, confusion, neck stiffness, nausea, vomiting, photophobia, which can even be seen in cryptococcal meningitis. So oftentimes people living with HIV, where every time they get meningitis, you get confused because their meningitis can be caused by a bunch of things, including even viral infections as simple as HSV giving you meningitis. So every time you see meningitis, think about syphilis as one of the differentials. Then you can also get what we call the meningovascular syphilis. Usually it presents about 4 to 7 years after the infection, and it can have things like hemiparesis, seizures, aphasia, and this results from from the syphilis. It causes end arthritis, the one we call and arthritis obliterans. So if the bacteria also affect the vasculature in the brain, you can end up with tiny areas of influx within the brain that can give you these other manifestations that we're talking about. The aphasia, the seizures, the hemiparesis. So all this is something to think about when someone gets syphilis. Then the last one is what we call the gumatous neurosyphilis. So this one may present with a space occupying lesions. So in this case, the gumas that you see on the skin, the person has it in the brain. So that one is also something to think about. If you do a CT scan or MRI, and then you have a space occupying lesion, and this particular individual maybe has a history of a primary chancre or treatment for syphilis in their course of life, or a typical skin rash in their history. Okay, so we can also get still in under neurosyphilis, you can also get what called the parenchymatous neurosyphilis. So this is usually characterized by gradual cognitive decline. Someone starts with retrograde amnesia, then they get psychiatric like uh, presentations, including getting psychotic disorders like even mania, forgetfulness, and the rest. So you have now to distinguish the parenchymatous neurosyphilis from psychiatric disorders. And these signs, they can also, signs in this type of syphilis can include papillary abnormalities, They can include hypotonia, tremors, the ones you see in Parkinson's disease, hyperreflexia, the ones you see in what any damage. You see, when you have upper motor neuron damage, you usually get hyperreflexia. So you find that syphilis actually can mimic almost every disease condition. So that's why it is very key for you to understand syphilis from top to bottom. Then the last one in this PowerPoint is what we call the Tibetic neurosyphilis, or sometimes we call it the tabes dorsalis. In this case, commonly seen, it was commonly seen in the pre-antibiotic era. These days, it's very hard for you to see it. It was by that time it was occurring in between 15 to 25 years after the primary infection. It included lightening pains, sudden lacerating pains in the lower limbs, and they could get ataxia. They could also get autonomic dysfunction, like someone, people presenting with, if someone has damage to the spinal cord, then they present with things like urinary incontinence, bowel incontinence. So even syphilis could give you a similar picture. And this one can also lead to development of the Charcot joints that we also see in syphilis. So you realize that syphilis actually can present like a multitude of things. That's why we call it the great imitator, or it mimics almost everything. So in this picture, this is an old picture where you have syphilis involving the last aspect of the spinal cord, giving the tabes dorsalis, and then because of this, someone also gets also what you call the Charcot joint, or neuropathic joints of the knee. That's what they will used to look like, as you can see here in those pictures. So those are the X-rays that we're showing abnormal alignment of the joints because of the damage to the ligaments that are supposed to give to keep the joint in shape. At the same time, you have lytic involvement. You are destroying the components of the bone by the bacteria, so you get that particular manifestation. And we call them the Charcot joints. Then for cardiovascular involvement, that is now in the tertiary syphilis, we get it affecting the aorta, so it gives you aortitis, so, and flags affecting the ascending aorta, and this commonly occurs about 10 to 30 years after infection, maybe asymptomatic, or you can have severe involvement where you have aortic valve incompetence, and then formation of aneurysms, which can rupture, and then someone goes and meets their creator. Other symptoms can include angina pectoris due to involvement of the coronary vessels, especially the arteries. And then in this case, after affecting the arteries, they'll heal by stenosis, giving rise to compromised vasculature supply to the heart muscles. So you get angina pectoris. So you see now that even when a patient has angina pectoris, you have to do a screening for syphilis. So that's what I told you, that syphilis can look like almost any disease condition. So when you go to investigation in syphilis, we usually do a dark field microscopy because you cannot visualize it with your normal light microscopy. Then you can do a PCR to look at its genome, and then the serological tests. So the serological tests are usually divided into two. We have what we call the non-Treponema test. So these ones usually test for the antibodies that you form against the syphilis. And then you have the Treponema test. Now these one tests for the antigens that are from the syphilis itself. So you can have the non-Treponema test, including VDRL, RPR, and then the TRUST. Then you can also have the Treponema test, including the FTA-ABS, and then TPPA, and then the TPI. Then you can also have the rapid point of care test. These ones are just rapid tests that someone can use to screen at home, and can also do cerebral spinal fluid analysis that can help us diagnose nerve involvement and neural involvement. So now these tests have specific sensitivity depending on the type of syphilis. So if someone has primary syphilis, the test, there's no single test that is 100% correct. The highest is the enzyme amino acid, which is up to 93% in primary syphilis, but this is not readily available. So you may find yourself having VDR, you can do VDR, you can do RPR, and then the test that you're doing, they're not 100% positive or specific. So you'll find that, for example, for VDRL, in primary syphilis, it is only sensitive about 78%, but in secondary syphilis, 100%, because now someone has really formed antibodies and the rest antigens are swinging left, right, and center. So all the tests are very effective in secondary syphilis. But when it comes again to latent syphilis, a few tests are 100% positive. Like even VDR becomes 95%, and when it comes to tertiary syphilis, it's only 71% sensitive. So you find that other things like RPR, it has a 68 in primary, 100, then 98, and then for tertiary, it has 73. So that's why you may need to do one or two tests at the same time, or even after a few couple of months, to make sure that you have not missed syphilis. So when you go to this when you're classifying them either under treponema and then non-treponema, this table tries to show you the importance of each and how you could use them. So when it comes to treponema tests, these are usually confirmatory because they help you detect the bacteria itself. The non-treponema detect antibodies, so they don't show you the bacteria. They don't tell you the bacteria itself, right? So when you come to treponema test, we usually use them as confirmatory tests for syphilis, whereas the non-treponema, we can use them for screening and monitoring treatment response. So the examples under treponema, as we mentioned earlier, we have FTA, ABS, and then TPHA, API, and then AIA, which is enzyme-linked amino acid. Then VDRL, we have it under non-treponema together with RPR and then the trust. So when you go to sensitivity, generally the treponema tests are very generally high sensitivity, but now the non-treponema, which varies with the stage, it is 78% in primary, 100% in secondary. Then when you go to the specificity, at treponema, since you are looking at the test which directly tests for syphilis, it is very specific, right? It looks for the bacteria itself. But when you go to the non-treponema, they are not specific because they can give even false positives. For example, if someone has malaria and you do the non-treponema test, you can end up being reactive, especially the VDRL can be reactive, yet in actual sense, it is not syphilis. Then when you go to antibodies detected in cases of treponema, we look for the specific antibodies against the pallidum, and then the non-treponema will look for the non-specific antibodies, which are usually reactive to lipoidal material, like the cardiolipin and the rest. So they are not specific, but usually we use them to screen syphilis. Then the timing of positivity for treponema, it becomes positive in early infection, whereas non-treponema will take about 1 to 4 weeks after the infection for it to be positive. When you look at the interpretation, so for the treponema test, because you're having the antibodies against the bacteria itself, you'll have, when you get an immune response and reaction, your body forms memory cells. So even antibodies, some of them remain as memory. So someone will remain positive for life. Whereas the non-treponema, the titers will depend whether someone is having an active infection. Like for VDRL, the titers will be high when someone has an active infection. Then they'll keep going down as someone is on treatment, and we use it for monitoring treatment. So basically, the treponema tests are qualitative, whereas the non-treponema tests are basically quantitative tests. So when you go to treatment, so when you're treating syphilis, this is now a recommendation. Depending on the type of syphilis, these are the drugs that you can use and the different regimen. So starting with primary syphilis, if you are to deal with the first line, if someone has early syphilis, that is primary, the secondary, or even early latency, you can use the benzene penicillin G, that is 2.4 mega units. You can give it as a single IM injection on day 1 and then day 8. Alternatively, you can use procaine penicillin G, where you give 0.6 mega units as IM once daily for about 10 days. But in our setting, we usually use the benzene penicillin that is readily available. But when it comes to late latent syphilis or cardiovascular syphilis, you have to do the benzene penicillin still. But in this case, you give weekly for about 3 weeks. So you can give on day 1, day 8, and then day 15. Those are about 3 weeks interval. Then when you go to neurosyphilis, you can use the procaine penicillin at 2 grams IM daily plus prosenecid at 50 milligrams orally 4 times, about 17 days. But if you are using penicillin, you have to give about 18 to 24 mega units daily. And then you have to give about 3 to 4 mega units IV every 4 hours for about 17 days. So for neurosyphilis, you treat for about 17 days. So you treat it for a little bit longer. Then in the second line, if you're dealing with early syphilis, maybe someone has an allergy to the penicillin, these are the alternatives that you can use. You can use azithromycin, where you give about 500 milligrams orally daily for about 10 days, or you can give even ceftriaxone injection at 50 milligrams IM daily for about 10 days. And this one, you only give it if someone has no anaphylaxis to penicillins, but then you want to use it as a second line. Then alternatively, if it is in a late latent syphilis, with maybe with cardiovascular involvement, if you are doing with cardiovascular tertiary syphilis, you can do your doxycycline at 200 milligrams once a day, about 28 days, as a full month. Or you can do amoxicillin 2 grams orally 3 times a day, plus a prebenecid at 500 grams orally 4 times a day for about a month. For neurosyphilis, you do doxycycline 200 for a full month. You can do amoxicillin together with the probenecid 500 orally 4 times a day for about 28 days. So syphilis, when it comes to treatment, you have to now first categorize which type of syphilis are you dealing with. Is it primary? Is it secondary? Is it tertiary? Is it having the cardiovascular involvement or no? Then you can know which particular medicine and how to give each drug. So thank you very much for this attending this one, and we encourage you to share with your friends so that they get to know about syphilis. I'm Dr. Abraham from the Dermatology Specialist, Uganda. See you in the next video.